Lisa, I'll turn it over to you for a moment.
Great. So I have just started recording. If anybody does not want to be on a recorded webinar, now's your time to sign off. So thank you so much, Leanna. This is Lisa Letourneau. I am internist by background and senior advisor, also in the Commissioner's Office at Maine DHHS. And as Leanna noted, we're just very pleased to have you here today for this next in a series of health equity webinars, which today is going to be focused on the topic of strategies for improving vaccine uptake in diverse communities and improving equitable distribution and uptake of COVID vaccine, which you only have to read the headlines for about 5 minutes before you see that that is clearly a continued challenge around the country. We have here today as our guest, Regina Phillips, who's the co-founder and chief operating officer of Cross-Cultural Community Services. Regina has a long history in working to address disparities and improve health equity, and we're very pleased to have her here today, along with Charles Mugabe, who is the COVID-19 project coordinator and liaison to the Maine ethnically based community organizations work of Catholic Charities. We sometimes refer to that as the ECBOs, and I'm sure you might hear that acronym sometime today. So I also wanted to welcome, I think have many clinicians who have been joining our half-an-hour sessions on Tuesday mornings, which we did not hold yesterday, in hopes that some of you would join us here today. So we're thrilled to have you here. And also just a heads up, the session is typically 60 minutes long. So just so you're not expecting us to end at 30, you can certainly go when you want. We are recording and we will be posting, and I'll put the link as Leanna mentioned. So with that, Leanna, I'll turn it back to you.
Great. So I thought we would begin by just taking a look at what disparities currently exist within vaccination. I'm going to share my screen for a brief moment. Can everybody see that? Okay, thank you. See some thumbs up. So what we're looking at right now is actually the dashboard that the Maine CDC, Maine immunization team has created to track the number of doses that have currently been administered in the state of Maine. And it tracks, as you'll see, both first dose and final dose by race and ethnicity. And because I've had this question a number of times, I will just note here that ethnicity is embedded in the race category. And so for each racial category, if you drop down, you'll see how many folks within that category identified as Hispanic, not Hispanic, or did not provide their ethnicity. When we look at the numbers, and let me just shrink this so that you can hopefully see it a little bit better. When we look at the numbers for racial and ethnic groups who have been vaccinated or at least received their first dose, what we notice initially, or perhaps the most notable thing here, is that the total number of doses, there's a significant number of missing racial and ethnic data. So 54,000 of the total 180,000 folks have not reported their data. And so we're looking at about 40% of individuals have not reported race and ethnicity, which is significant. We're also looking at the numbers of those who did report. What are we seeing in terms of racial and ethnic disparities? And what we're seeing is roughly 1% of those reporting race and ethnicity identifying as Black or African American, and roughly less than 1% identifying as Hispanic, which we know is not quite in line with their census population statistics, nor is it certainly in line with how we know that COVID-19 has disproportionately impacted those communities. And so we're certainly beginning to see a gap in vaccination, but it's hard to know quite how big that gap is because of this big missing number, right? Because of this 40%. And we can't make assumptions about that 40% and who is or is not missing from it. So I'm going to stop share for a moment. So as we think about the 40% of race and ethnicity data that is missing, we know that that's really different actually from what we saw with COVID-19 case data. In the case data, we see about 12% unknown for race, although we do see a significantly larger number for unknown ethnicity, which we'll talk about in just a moment. And there's a couple of reasons that may explain that. First, I think we've heard from providers that there was a general misunderstanding about what optional meant. And so race and ethnicity data, just by way of a background, is optional for the patient to answer, as many of you know. It is not optional to ask, and it's definitely not optional to report to the Maine immunization program. And so we have been working with providers to correct that, and certainly some providers are now going back and doing some self-auditing and trying to bring that information into our system, which should shrink the number, but again, probably doesn't explain for the entire number. The other thing that might explain it is perhaps we know that it's optional for patients to answer, but not everyone's asking. And again, that seems like a relatively simple fix, right? Making sure that people are aware that they need to be asking patients this question in forms in a meaningful way, and that they need to be, for those who are actually doing registration for vaccination, need to be asking as well. But I think that the most important one that we'll come back to the best practices around this in a moment, is really, are we asking in a meaningful way? Are we asking in a way that helps patients understand why we're asking for this data? Are we asking in a way that helps patients to understand what we will do with this data and how we protect this data? And so ensuring that we are really utilizing best practices for the collection of race and ethnicity data is equally as important as ensuring that we're asking it to begin with. And so we'll come back to that in a moment, and we'll talk with our panelists a little bit about how they help members of their own community understand these questions, and how providers might be able to have those conversations with all of you. One of the things that we really need to think about is, why does this data matter, right? Why is it important that we're collecting this data? And obviously, one of the reasons is accountability and transparency, right? We've certainly seen a disproportionate impact for COVID-19. Communities are aware of it. There's been lots of talk about it. So what does that mean when we get to vaccination and ensuring that there's an equitable distribution of vaccine? We want to make sure that we are being transparent about both our efforts to achieve that equity and our successes and challenges in achieving that equity. I have a good friend who works in data research and always says, no data, no problem, no solutions, right? So at its simplest, if we can't see what's happening, then we can't identify where we have gaps and challenges, and we can't tailor solutions to fix that. And so 40% missing data is really hindering our ability to do that level of analysis. And this is certainly not just a Maine problem. There's been lots of news recently released around this very topic, and we're seeing nationally that the federal government only has about 52% of race and ethnicity data for vaccination. So this is not just a Maine problem, but it is one that I think we can begin to chip away at here in Maine. And so I wanted to focus on that today quite a bit. The other reason that it's important is that we know that there's a history of racism in healthcare professions. We know that there is a very real disproportionate impact of COVID-19, and that there are histories of trauma that really inform people's decisions to be vaccinated and inform people's level of access to vaccination. And so it's critical that we begin to analyze that with the data that we have, but also utilize initial conversations in which we ask for race and ethnicity data as a place where we can begin to build trust, as a place where we can begin to repair some of those challenges, and begin to chip away at some of the challenges with vaccine confidence. So I think I'd love to hear, I don't want to hear me talk this whole time because we have such wonderful guests with Charles and Regina with us today. So I thought we'd start there and talk just a little bit about this history that may be fueling some vaccine hesitance, but also some barriers to access for communities of color. And talk about, how do you think I'd love to ask the two of you how you see some of those histories of racism in the healthcare profession and of discrimination playing into vaccination and the decisions to be vaccinated or where to be vaccinated and when to be vaccinated for communities of color in Maine.
Regina, I'll let you go first.
Thanks a lot, Charles. Well, it's really good to see everybody this morning. I see some friendly faces here, and Leanna, thank you, and Lisa, you as well, for having Charles and I here. The data you provided is amazing. I hadn't seen it before, and to know that 40% of folks aren't reporting their ethnicity, obviously that is a major problem, and we need to, folks in the community need to figure out how we can let our communities know that it's okay to give your ethnicity when you're taking a shot, because it's only going to help out the data. But the other thing is that we live in this history of systemic racism, and that is in many, it plays out in many professions. Healthcare is just one. I mean, we could go on and on and on. And within the healthcare field, we know that Black people and people of color have been used for centuries, right? For 400 years on many experiments and research that hasn't gone well. I mean, we all know about the Tuskegee syphilis experiment, but we don't, some of us don't know about the J. Marion, wasn't his name now, experiment. He was a gynecologist. We also know about all the experiments that were done on slaves. We also know about Fannie Lou Hamer, who went in for a simple procedure, and then she was given a hysterectomy. And not only that, but we also know that there was laws on the books. There was laws on the books that would treat Black people different than they would treat white people. And like I say, this is about systems. So it's not just about the healthcare system. In Maine, I don't know if many of you know, we had Malaga Island. Malaga Island is an island off of Pittsburgh near Bowdoin College. And there was a community that was living on Malaga Island. And this was a mixed race community, many fishermen that were living happy on this island. They had a cemetery, the kids were going to school. Again, very happy, and they were living there. They were evicted. They were evicted by a Democratic governor in 1912. Years later, Governor Badachi had everybody out there and he apologized. But the reason why I'm telling you that is because there's not only a mistrust in the healthcare system, there's a mistrust in our government as well. And so when you're talking about vaccines and you're saying this is coming from the government, please trust us, right? Black people are going like this. Okay, well, first of all, you really don't want us to be here. You're not giving us all of the medications that we deserve. You don't think that we feel pain. And so that's just the healthcare. And then with the federal government, you've been discriminated against me for 400 years. So now all of a sudden I'm supposed to trust the system that you have set up that we know is racist, and you want me to get a vaccine. And not only that, but there's just a lot of data out there that says, right, Black people are getting the virus more than white people. White people are getting the vaccine and Black people aren't, right? And so there's all of this data out there, right? And so people are like, they're confused and they're thinking about the history of racism and they're thinking about oppression and they're thinking about all of these things and they're going, I'm not getting the vaccine. Not only am I not getting the vaccine, but if I do get the vaccine, I'm not going to tell you who I am, because then that just leaves the door open for you to, use my record or discriminate against the next Black person that's going to come into the room. So I apologize. I'm going to stop talking because I'm not sure how long I was supposed to have, and I just keep going on and on and on and on. But I do want to tell you that the last thing I will tell you really quickly, because I want to give Charles some time, is, I trust my doctor. I absolutely love my doctor. My husband loves his doctor. They have this really good relationship. But part of this also is the intergenerational aspect of things. And many of you have heard me talk about my wonderful mother. She's 85, but I often tell this story. She refused to take a Tylenol because her shoulder was hurting and her doctor told her. She refused to take Tylenol, and because I told her, because she also doesn't, I mean, let's hope she loves her daughter. But anyway, my profession is a social worker. I have a master's in social work. And so I'm a social worker. So often she'll say to me, she says, you're just a social worker. Your jargon is the same. Refuse to take Tylenol. She only took Tylenol when she went to church. And she talked to a nurse there who said to her, I think you need to take Tylenol and your shoulder will be better. That's why she took the Tylenol, not because of me. So I'm gonna pass this on to Charles, and I'm gonna get off my soapbox.
Thank you so much, Regina. I think you touched on very key points. I just want to say thank you to Liana and Dr. Lisa Letourneau for inviting us here. It's truly a privilege, and we do appreciate it. And good to see everyone here too. Before I start, I wanted to touch on the data a little bit and just say, speak from the perspective of an African. Myself, I came from Africa about 5 years ago, and it's been kind of an interesting journey being able to, to learn along the way as a refugee. Since I left my home country a while back, and then, I was a refugee in Uganda for a couple of years, and then traveled other countries, and then finally came to the United States. So all that experience was kind of very interesting. But speaking from a refugee point of view, when you talk about race and ethnicity, race is something that we know, right? Race, we are Black, of course, but when it comes to ethnicity, in the refugee world, ethnicity doesn't exist. Most of us, we know ethnicity as tribe, right? So when you ask somebody what is ethnicity, they will be thinking of their tribe. And most of folks are not comfortable disclosing their tribe just because of the conflict, the tribal conflicts that exist within Africa, which caused blood shed. People died, people killed each other, and even when they're here, that history still sort of like follows them in a way that even here, some people are still not comfortable disclosing their tribe. So when you're asking somebody about their ethnicity, you have to be thinking that this person doesn't know exactly what you're asking. It's not only why, but also what is it? And when you say like, hey, you know what? I'm not asking for a tribe. I'm simply asking, whether you're from Africa. The data that I need is just Black or African. That's all I need. I do not need your tribe. This will make them even more comfortable to share that with you. So I just wanted to put that out there. And then the second piece is, for folks from a Middle East, for example, at times it's really hard to tell what the ethnicity is. Just because they look white, you cannot say they're Black. You at times, most of the health professionals are hesitant to say they're white either. At times we want to categorize them as Asian, but the truth is that their race is also white. And sometimes when you ask them about it, they themselves do not know about it. So at times it's not just how or why. At times it's what exactly is it about ethnicity that you're asking, and that way you can collect as much information as you can from that perspective. I just wanted to throw that in there from a refugee perspective. Coming to racial and ethnicity, when we're talking about the bias or the way the system is shaped, or the difficulties or the past histories that the Blacks have had or Africans have had, speaking from an African perspective again, it's quite a lot. I think most of you are aware that most of the vaccine trials, especially past vaccine trials, have been done in Africa. And this has been something of a habit within the health system of the world, in a sense that Africa has mostly been the testing ground for most of the vaccines in the past. And when right now speaking to an African about vaccine, that's the very first thing they're worried about. Like, hey, you're talking to me about vaccine means that I'm probably going to be tested, but that's not what you mean, right? And that piece I think has to be clear in a way that, for example, we know how the vaccine was made. We know what happened. The trials already happened. Between 30,000 to 45,000 individuals were tried on. And these folks represented different races, different age groups, and they were all being tried. And that stage already passed. It has been approved already. It's ready to be administered. even though it's on emergency level. So just being able to explain that piece can help somebody calm down, because we've seen trials happening in West Africa, for example, against the meningitis with Pfizer. But back in the 1996, for example, just in Nigeria alone, Pfizer were doing testing on, were doing trials on folks. And at times, what they did there, some folks didn't even have, they didn't consent to such kind of trial, just because the vaccine, there wasn't a healthcare system to support the pandemic there. Folks were relying on whatever help they could get, and healthcare systems over there took advantage of them and just kept doing trials on them. And what was the result? Some of the kids died, and some of them afterward were left with serious health issues that until today, folks are truly afraid of vaccination trials. And these are things that happened not only in West Africa, but also some other parts of Africa. Now, for that exact reason, when you're approaching somebody, talking to them about vaccine, it's quite important to put all this into perspective so that you are not narrating your own story to understand where they're coming from, but rather talking to them, speaking to them, be like, hey, you know what? Why are you afraid of the vaccines? Because that's the only thing they want you to say. And that way they explain their point. And then you can present them with fact to help them understand why you think the vaccine is safe. So the system really, especially in Africa, it's been challenging for us. So when you're speaking to an African person about vaccine, it's truly necessary to be very careful and just listen to them and figure out why they're hesitant, because they might have a good and valid story of a friend or neighbor that passed away just because of the trials they've experienced in the past. And these are very critical and very important history that they're still holding on. And that, the reason why is most of them do not want to take the vaccines. So I'll stop there and let Liana continue. Yeah.
Thank you so much, Charles and Regina. And it is really a rich, and by rich I also mean traumatic history that is really important to honor and to understand as a driving force behind both some of the hesitance to receive vaccine itself, but really the hesitance to answer these kinds of questions about racial and ethnic data as well. And so I appreciate both of you highlighting just a few of those examples for the communities that you serve. I did want to share very quickly just a slide that Dr. Sandra Quinn, who did an earlier webinar with us around vaccine hesitancy, and her research out of the University of Maryland really focuses on vaccine hesitancy with the flu vaccine, particularly in the Black community. And this was a slide that I found particularly helpful because it really does highlight the way in which it is that history and those experiences that influence not just our trust and our perception of risk, but influence what information we have access to or are ready to really receive, right? It's different. Often I hear people say, I don't know what else we can do. There's all this information out there. But if your relationship to those putting the information out, whether that is the government or the healthcare system, is one that is not yet built fully on trust, it does make it hard to receive that information and filter it. And so while it can seem separate, it really is that historical context that feeds into all of the factors that people weigh when making an ultimate decision about whether or not to receive a vaccine. And I really do see the opportunity to ask about race and ethnicity as an initial place to begin to build that trust and recognize it not just as an important part of collecting data and holding ourselves accountable, but really an important piece of building that trust. And so I do think there are some best practices to collecting that data that are worth sharing with all of you. And we've created this one pager, which is on our website, with the provider information now. If you want to grab it off of our website, you're welcome to use it for any of your vaccination locations or in training for those doing registration for vaccine clinics. Really, it's about creating a consistent practice, and that consistent practice needs to ensure that anyone collecting this data, whether they're doing it live or whether it's happening in a forum, is providing a rationale for why we are collecting this data. You heard Regina say that there's going to be suspicion about why, right? How do I know this isn't data being collected to discriminate against me, right? I have good reason to think it could be. And so really making sure that those who collect the data understand that rationale and can articulate very clearly, we need this because we care about equity, because we understand that there's been a disproportionate impact. And we know that that means that we have to make sure that vaccine is rolled out proportionately. Making sure that we are providing that training to make sure that staff understand how to ask. Lots of research has been done, which demonstrates most staff is actually pretty uncomfortable asking, right? There actually is an understanding that those on the receiving end of this are going to have discomfort being asked. And so there is discomfort in asking. So helping your staff to really understand and giving them a script, right? Sometimes the easiest way to deal with discomfort is having a script. I often talk about the example of my own child who was going in for a procedure, and I got a call from their healthcare provider to do an initial screening, and they asked me a million uncomfortable questions for a 12-year-old child. I mean, a million uncomfortable questions. And I thought nothing of answering any of them because I could understand that they needed to know this to make sure she was safe. And at the very end, the thing that they said to me was, I need to ask you about race and ethnicity. The federal government makes me ask you this. And I have to say, even given what I do for a living, I hesitated for a moment because that was the worst lead-in I had ever heard. It demonstrated that the person asking had no comfort in asking me this question, and they themselves didn't see the value the way that they did when they asked me if my 12-year-old was pregnant, when they asked me if my 12-year-old had used illicit drugs, right? So I think that if we can use that same confidence that this is related to a legitimate medical reason and a legitimate reason for the achievement of equity, then we can gain some comfort in asking that in turn will translate to comfort in answering those questions. And so I would really highly recommend collecting this information with a script that includes a justification and includes information about where this data goes, what we do with it, and who can see it. There's certainly, especially for those whose immigration status may not have full citizenship. There's always a lot of suspicion and fear when people are asking about who you are and how you identify. And so being able to talk about where we keep this data, who has access to it, and why we use it is really critically important, and making sure that those collecting the data are prepared to answer those questions. And then, as you heard Charles say, really understanding the difference between race and ethnicity. I think it's okay to say to people, this may not be how you yourself would identify yourself. In an ideal world, we'd have room for people to self-identify, and we would have a standardized approach to roll that up into the OMB standards, but we're not there yet, if I'm going to be honest. And so what we do have is at least the ability to explain what is meant by race and what is meant by ethnicity, and to acknowledge that it may not be exactly how you yourself would identify yourself, but that there's still value in answering that so that we can understand health and equity. So I'd love to hear from Regina and Charles, what, in your experience and in working with communities, what has been effective in communicating both and I would broaden the question, what has been an effective way of communicating why we ask these questions, but also then communicating trust, not just in the information that we collect, but in the information that we give. So we're collecting the information about race and ethnicity, but we're giving you information about your vaccine. And so what helps or what makes for effective conversations with providers for your community?
Regina, you can go first.
Oh, thanks, Charles. Thanks for the question. So I'm going to go back a little bit. Thank you very much for the race and ethnicity documentation form, because I think we can definitely use it in our communities. But I'm going to go back a little bit, because the reason I'm going to go back a little bit is because given that mistrust, there's so many things that we need to do before we get to the conversation about somebody's healthcare and why they're in your office and why you're asking these questions. There's so much more we can do. Because here's the thing, when a Black person walks into an office, when they walk into a school, when they walk into any place they go to, they want to see posters, they want to see people that look like them. Automatically, if they don't, that's going to set up an us versus them, and people are going to go back to the trauma. They're going to go back to the oppression. They're going to go back to all of those things that have happened where white people didn't see Black people as actual people. Right. And so there's so many things that you can do. You need to have the posters, you need to have the staff, which means you need to look at your hiring practices, right? You need to say, you know what, I have these two people here, one's Black, one's white, I need a secretary, or I need a nurse or whatever. So I'm going to go out on a limb here and I'm going to hire the Black person because I want Black people to come into my office and see that I have Black staff, or I have a Hispanic staff, or I have, you know what I mean? And then that is going to set up the trust. Okay, but it's not even just about the posters. It's not even just about the staff. It's about how you interact with somebody, right? And so, there was a question in the chat about, what do we do now that we have this history, right? There is a different way you can ask these questions, right? I know you only have a couple of minutes, to talk to somebody, but you don't go in there on your computer and just ask these questions. You go in there as a human and you say, I don't mean to be disrespectfully. I know you treat all of your patients very well, but whatever. So, but there is a way to do it a different way. When you ask somebody, tell me your story. Tell me your story. I promise you, you will get to the same answers that you want if you just ask somebody to tell me your story. Will you spend a couple more minutes with them? Maybe. And I completely understand that there's not that time or whatever, right? But if you ask somebody to tell you their story, you will get around to how did you arrive, or what's your family history? How many children do you have? Why did you come here today? You will get to all of those things. But somebody wants to come into your office and they want to know that for that couple of minutes, those minutes that they're there with you, that they are given your full and utter attention. And that you actually care about what they say, and you care about their history, and you also understand the history. And so that's the other thing. Give yourself some education, look up the research, just so you have it in your head, right? Not that you have to give it to anybody, but know the research, know why that person is hesitant in giving you with all of this information. Right. And also just look at some things that about somebody's culture. I used to work with a gentleman at Maine Behavioral Health. When I worked at the city of Portland, we had a survivor of torture grant. And he was a white guy. He was a social worker. And most of our clients were from Somalia and Sudan and Iraq. But when you walked into his office, he had memorabilia from all of the patients he had from these countries. And so what happened was somebody would come to his office and they'd go, whoa, wait a minute, you got this and you've got that. It started the conversation that was able to build trust. And so therefore, the patient's level, their stress level went from 100 to 10 because they figured there was some kind of understanding about their particular culture and about them that he actually cared about.
Beautiful said, Regina. Thank you. Yeah, so from my perspective and what we've been hearing on the ground and what we've seen so far, it is indeed true that it's very difficult to communicate with somebody about vaccine when they do not trust you, because whatever you say, they're not going to listen, first of all, and they're not going to take in, and that is not a productive conversation at all. And as health experts, we always have our version of narrative. We always want to diagnose somebody. We always want to figure out what's wrong with them. But this COVID-19 pandemic time, this with the mixtures of histories, mixtures of concerns, distrust, it's not about what you know. It's about trying to find out what is their concern and how you can step in to support them. And I think that coming from that perspective is way better than being like, hey, I know you're concerned about your immigration status. Oh, I know you are from Africa, and you might be concerned about this. No, it's not about assumption. Hear their side of the story and figure out how you can work with them to help them understand what is actually going on here. Because like most of the times, I think one thing that we've been hearing a lot is that people trust their doctors, people trust their nurses, people trust their hospitals. But people from my community do not trust doctors, first of all, because they do not even have doctors. Some of them just go in to see different physicians and they don't know who exactly is their primary care provider. So in that sense, you cannot tell them, like, you cannot assume that, hey, because I work with that family, they trust me. No. From our community, that's not how it works. And what I know for sure is that people trust their community leaders. People trust their faith leaders. People trust people from their community that represents them. And when you're talking about effective way to communicate with mass population, this is one way of doing it. Reaching out to those community leaders, reaching out to those faith leaders, see to what level you can collaborate in case you want to do a mass education. And from your office perspective, I think Regina's suggestion is so good. But I also want to add that you have to self-reflect within your system. What is it that what are some of the ways you could do better? You could change your staff, yes, but what are some of the other ways that you could assure that when somebody of color or somebody from a different community that does not usually trust you comes in, what are the different things that they could say and still feel safe? Like they can talk to you about what they have, about their problem. So it's about self-reflection, internally looking on how to improve your system. What Regina pointed out, I think, is really good, because most of the times, even me, myself, when I go to the hospital, the nurses usually just go to their computer, type, and that's it, asking questions, answer question, answer question, answer, and I leave with either prescriptions or nothing, or just as basic information. But the point here is to truly settle down and consider that this person might be having more than regular issues, that you're not just there to diagnose this person, but also, help them understand what vaccine is. Because if we're looking at minority communities right now, people have lack of access to informations. Some people do not know how to use computer. They cannot do their own research before going in for vaccines. Some people, they cannot even schedule their own appointment to get vaccinations because they don't know how to do so. And these are things that systems could be reflecting at and be like, hey, you know what? We have a website for people to sign in, but how can we do it to go even a step further? For example, when we're posting our website, how can we add a phone number or give them a resource of a phone number where they can call and still get answers? Or how can we improve ourselves so that somebody who doesn't speak English can still feel like they can communicate with us? So thinking a little bit wider, thinking about those communities that do not usually have access is one way to extend your reach, and not just limit to what you've done and check book and be like, well, I've done this, I'm all set. No, it's about thinking, it's about expanding your reach and be like, well, what else can I do to support and to make this work effective? I think I'll stop there and not continue talking the entire day, Liana, but thank you.
No, thank you. And I'm seeing some of the questions about community health workers, which is a really great transition to my next question, which is really, if we could just hear from each of you about some of the efforts that you are seeing in communities to get the word out around vaccination. And I'll start us by saying that at the department, we've created a small working group that really combines some folks from the department and some community leaders. Regina sits on that group with us, and have been talking quite a bit about not how we do the education, but how we can be bridges to community leaders and support them by ensuring that they have the clinical support that they need to do that education and outreach, but are really relying on the leaders in the community that are, as Charles said, really the trusted voices, really, and probably most able to make an impact there. And one of the things that we've certainly heard from all of the community members on our small work group is both the importance of trusting their community and partnering meaningfully with their community, but also what we've heard is a bit of a reframe from where we began, which was let's get shots in arms. Let's get to herd immunity. We all want to see this end. And folks really asked us to hit pause and say, no, how about let's give people the information they need to make informed decisions for themselves, which really goes to the history that we talked about in the beginning, and the need to honor really the agency that each individual has to make his or her own best healthcare decisions in partnership with healthcare. So with that, I would just ask Gina and Charles, if you don't mind sharing a little bit about the work that you're seeing in communities happening around vaccination and what you think has been most successful or most promising as we move forward.
Regina, you can go first.
Thanks, Charles. First of all, I want to say that folks in the community, folks in my community, we can't do this work by ourselves. Right? I mean, I'm not a doctor, and so I can't do this work by myself. I can have some of the information. I can go out to my community. I can talk one-on-one with folks, and I can do all of that. But I absolutely need to have the professionals in the room with me. And that's why I'm just glad how I feel like I have a great relationship with members of the CDC. I'm grateful that I have a relationship with Dr. Letourneau and Leanna, because then I can say to people, hey, listen, I know these people. It's okay to trust the CDC. They have this information. I've heard it from folks. Let me give you the statistics. Let me give you the data, right? I can go out there and I can tell, folks in my community, you know what? There is no reason for you not to take the vaccine. It has been vetted. So those are the conversations I'm having in my community. The other thing that we're doing at Cross Cultural Community Services, and it's not just me, we're working with several folks. I've seen Alita Burke on the call, and she's one of the organizations that helping us. And I don't know if anybody from Gateway is on here, or Maine Access Immigrant Network, or some of the other partners that we're using in order to do a Black History Month community wellness fair, because we want to get the information out there, and we want people to hear from folks. We also want people to know that we have to work with our white allies. We have to. And so we are very, very grateful that Dr. Letourneau is willing to give up some of her time, and Dr. Shaw, because one of the things we're going to be doing next Wednesday evening, a week from today, is we're inviting them to a session during our week for them to give us, some information on the vaccine, to give us some information on COVID. And let me not forget, we also have Leanna that's going to be on that panel as well, and Crystal Williams, who is directing this work. And I am just so grateful that these folks are going to come into my community. And when I say my community, I'm not just talking about the Black African American community. I'm also talking about Charles's community. I used to run the Refugee Services Program for the city of Portland, and so I'm just so, and not only that, but some of the other communities that will hopefully tune in, so that they can hear right from folks. And not only that, they can see, they will actually be able to see my relationship and my interactions with Lisa and Leanna. And that will open up even some more trust within the medical field. And so we constantly have to be out there talking to folks within our communities. We have to constantly be working with folks. I also see Chris Pasillo on this call. Chris and I have done some work in the last several months in getting this same information out to doctors, so that they know what's going on. And that's why I'm grateful that we have all of you here. I also see Mo Wall on the call from Maine Medical Center. The other thing we have to do is we have to go out there and we have to talk to folks in our community and convince them to go into the healthcare field. Right? That's also going to cut down on stress. I know that was a little off because that wasn't really the question you were asking. But anyway, it's all about having conversations within our community. It's all about letting people know that we have to have relationships with everybody if we're going to go ahead and move on from this pandemic.
Thank you so much, Regina. What I can truly say is that we're all very, very concerned about this pandemic, and everybody's doing whatever they can, no matter where they're from, no matter what their office is. some of the offices that don't usually do health work, they're also embarking on the responsibility of being able to provide education and outreach material, or just holding sessions for communities that they work with. And this is a time when everybody is doing everything, all right? At times, some people are doing it on their own. At times, folks are doing it in partnership with other community organizations. And I just really want to encourage the health providers to really reach out, because you might, just so you know, everybody's doing, including Catholic charities. We're also doing education and outreach to all refugees that have arrived so far. We have different programs. For example, we are sending them messages through WhatsApp, where we have nearly 100 of participants in that WhatsApp group. I know Maine, they're doing I think, bi-weekly sessions in partnership with Maine Medical Center to teach their community health workers and the community about vaccines. I know different groups doing different kind of work. And this is exactly what we need to see how we can help each other and grow. Because I think, Regina, you're absolutely right. We're not health experts, right? We are just starting to learn about all this thing, and we absolutely need help. And the help we've gotten from state is absolutely wonderful. We also want to get help from our health providers. We also want you to be part of our efforts, because I like the way you framed it, Regina. That's the best. That's the way they can also see you being part of the community indirectly and beginning to trust you. And I think, it's time to look at how can we collaborate? How can we do the work better? I want to give an example of a recent clinic that just happened last week. Catholic Charities, in partnership with other community organizations, we did an arrangement with Mercy in an elderly home on 100 State Street. And at first it seemed like an impossible task, because it's a huge building, lots of people. They have lots of people from minority community, elders from minority community that live there. It was just challenging to start thinking of how and where can we start. The partnership made it possible in a way that many people participated in their own way. Some made video materials, some of them made audio materials, some of them made flyers, the other ones made calls, the other one sent message through their WhatsApp group to the people that live in those buildings. And the day the vaccination was to happen, it happened within the building, and we had more than 65% turnout for vaccination. And that is that's by far, compared to other clinics that I've heard has happened. So you can always want to do your own thing. You can always want to go on, and let's say you're going to an elderly home and do your clinic. Absolutely. But if you had 1 or 2 or 3 more partners with you, they won't mess your work, but rather make it even better, because they will bring in resources from their side. If it's a residential home with immigrants, they can, you can work with a community partner, one of the ECBOs that can come and support you, provide language support, provide interpretation on site on that specific day. So there are a wide range of work that we can always pull in to make our work better. And this is that exact moment. It's not about doing on our own or using our own capacity, but rather reaching out to people and collaborate to make sure that we're doing work for the community. It's not a competition, but rather we have to support each other and improve uniformly, because we don't want anybody left behind. So that's the only example I wanted to share. And thank you, Liana.
Thank you so much. And I will just highlight very quickly that during the Thursday vaccine work group calls with many of the providers receiving vaccine from the Maine immunization program, we're going to begin to highlight some best practices in collaborations to achieve just that. So if you haven't been attending those, or members of your organizations haven't been attending them, I would strongly encourage you to do so. We'll start by highlighting some of the work that Northern Light Health has done tomorrow to collaborate with communities in order to achieve health equity. I did see, sorry, Nelida, I missed you. I was about to go to you, and she just messaged me that she had to jump off, so I apologize. We have a few more minutes. I don't know if there's any folks have questions for myself or Charles and Regina. I'm happy to take a couple of questions.
Hi, this is Amy Gamble from Northern Light Mercy Hospital. Can you hear me?
Yes.
Sorry,
Great.
you're on the phone. You may not be able to see me. We can hear you.
Okay, great, thanks. I just wanted to highlight, that story about Mercy. This past weekend, I was there for the clinic. I help run our clinics there, and it just went so well. And without those fabulous cultural brokers, we couldn't have done it alone, clearly. And we're really so grateful to be able to service that community. And the people that have come to provide those interpreter services have just been immensely helpful to us. So thank you for helping us be connected.
Thank you so much. I did just want to highlight one thing, which is earlier in the chat, I noticed there was some conversation about the population distribution in 70 plus, and rightfully so, because at least with respect to new Mainers, we know that they skew younger. And so we are talking about smaller numbers in the 70 plus that are eligible for vaccine. But I did want to also highlight just how critical this moment is, right? It may mean that there is a relatively low uptake of vaccine in communities of color, particularly for new Mainers. But which may be driven by the number of people eligible and may be driven by other factors in vaccine confidence. But what we have is a moment, as Regina said, to start showing communities that we're working collaboratively to meet their needs. And so it may not be that there are a ton of people eligible now, but seeing providers in community with trusted community partners and leaders may make all the difference when we move to phase 1B of essential workers, or when we move to the general population, in really ensuring that people are ready and willing to take that vaccine. Early on, we definitely saw higher declination rates in long-term care facilities. But when providers went back with members of the community who maybe were willing to take that first round of vaccine, we saw more and more people raise their hand, right? And so we know that this may be, as one of our work group members said, this may be slow medicine, right? This may take some time, but that's the benefit in some ways of doing that now, even where very few may qualify, because when we do have enough vaccine to move to those latter stages, it may make all the difference in equitable uptake. Any other questions? Charles, go ahead.
Thank you so much, Liana. I just wanted to add there that most of community-based organizations, including CAP agencies, they've received contract from. They will be contracted with DHHS to do vaccination work. So I just wanted to really say that if you want to partner with any organizations, especially those who will have contract with DHHS, you do not have to be worried about how to pay them. It's just a matter of being like, hey, you know what? Let's work together. Let's do the work. I just really wanted to highlight. And then the second piece I wanted to add there about the equity distribution is that we always wonder what exactly that is. But that is exactly what we're talking about here, being able to push your hands a little bit further to the community that don't have access, the community that are not able to get it for some reason, that are hesitant to get it, and being able to work with community leaders, so on and so forth, to make sure that there's vaccine accessibility in the immigrant community, because it's not only hesitancy. Most of us are working hard, and we're all working hard to fight the hesitancy. We've started the battle, and I think we're coming, it's never going to end, but we also have to think about vaccine accessibility, which will be a challenge, or is a challenge in some places that we're seeing right now. I just wanted to add that piece. Thank you.
And while we've focused these webinars on racial and ethnic disparities, I do want to also highlight that certainly from the federal government and from the state's perspective, there are other aspects of equity that maybe we don't even have data. We have even less data to measure, right? And so as part of our work group, we have certainly been talking about homelessness, as well as the LGBTQ plus community, and rural access for those who are homebound. And so I do want to sort of name that in this conversation, though we have not explicitly focused on it here, that it is very much a consideration and something that we are focused on as we have these conversations around vaccine equity.
And those living at the margin of the economy, which is maybe one of the biggest disparities in the state right now.
Absolutely. Absolutely. Thank you.
There is a question, Liana, and we're getting close to the wrap here, but are cultural brokers included in the phase 1A category? And I will jump in to answer that. Only if they otherwise meet one of the criteria for 1A, which is front-facing healthcare personnel, public safety, or adults living in, or individuals living in long-term care settings. So I'm guessing that most unfortunately are not, but as we all know, the whole phase discussion is another giant one. That's a lot of challenges in there. So I did put in the chat the link to where these webinars are posted. It'll take a few days, but we'll get this one up as well with help from our friends at CDC. And then also the link to register in advance for this monthly series. So folks certainly are welcome to register anytime. Next month, we are planning to, so it's exactly 4 weeks. So what is that, March 17, and focus again on this topic and highlight best practices of organizations that are doing good work. So as Liana said, we're going to introduce some of that in the CDC COVID vaccine provider calls on Thursdays. Those will sort of be brief highlights. Next month, we'll focus the whole hour on what folks are doing out in the community, whether it's getting people to share that information when they register, at higher rates, or engaging communities, or engaging people in uptake of the vaccine, et cetera. And if anybody wants to volunteer for that, please feel free to contact Liana or me directly. So with that, Liana, in closing, should we wrap?
I think we can wrap. I would just say that if you're intrigued by ideas about how to partner and you're not sure how to do that in your community, you can always feel free to reach out to me or Lisa, and we can try to help direct you to organizations working to meet the needs of some of your patient populations. As Charles said, we've got a lot of organizations that are working under state contracts to provide these services, or will be soon. And we are eager to help make those connections and make this work a reality for all of you and all of our communities. So please feel free to reach out if you need help with that.
So thank you again, everybody, for joining. Thank you, Regina and Charles, for sharing your perspectives. Liana, for leading us through this work. And we will look forward to seeing you all hopefully next time. Thank you.
Thank you very much, everyone. Thank you, Liana. Thank you, Dr. Lisa.